Hello. Uh, Hello, everybody. Bonjour. I hope everybody has been enjoying this beautiful Mediterranean Sea of Cannes, France. Unfortunately, the weather isn't helping us, but I know everyone says there's always a brighter tomorrow. I am really honored and thrilled to join this journey of inspiration of knowledge, which is the Megamind. A quick introduction of myself. My name is Dr. Scott Jung, and I come from the Canada, a city called Vancouver, located in the West Coast. And I am a dentist with a heart and passion for implant dentistry. And I practice as a general dentist at my own clinic called Cloverdale Dental Center. And I also teach a little bit of implants to other general dentists as well in my city. And I love implants, and it's my passion. And the reason why I love it is because it opens up a new chapter of rehabilitation for my patients. Many times, my patients will suffer from loss of mastication or low self-esteem due to their broken teeth. But now with implants, I can restore their form, function, and longevity almost instantly. And that is an amazing tool to me. And I've done ranges of implants from simple to complex, from immediate and delayed, and I've done them all. But out of all these things, my favorite ones are going to be anterior cases. And I like them not because they're easy. It's quite the opposite. I actually like a little bit of challenge. Anterior cases always brings a unique set of challenges that we need to overcome. And we talked about anterior cases all morning, but I come with a question that I want to ask all of you guys. And the question that I think is, what is an aesthetic anterior implant? And to answer this, let's go to a case together. Rob is my favorite patient because he's always full of smiles and he always makes everyone laugh in my office. Unfortunately, he's been suffering from an intermittent fistula on his front tooth, which was diagnosed as a vertical root fracture on tooth number 11. And knowing that this has to be extracted, the patient is aesthetically concerned about missing his front tooth and wanted the best option to replace it. And everyone in this room now knows that the best option nowadays to replace a tooth is immediate implant therapy. There's many articles out there, and I'm just going to mention one. We know the immediate implant has the best option to preserve the peri-implant tissue without actually increasing the failure rate. We talked about this. So now we live in the days of immediacy as a standard treatment. And for anterior cases, what we talked about, we talk about because we all want predictable aesthetic outcome. And one of my favorite mentors, Dr. John Coyce, has set out these 5 diagnostic keys that we need to look out for. And Rob scores 4 out of 5, with the tooth coronal to the adjacent teeth, thick gingival biotype, oval and square tooth shape, and most importantly, the osseous crest, 3 millimeters from the gingiva, which all these making it for predictable aesthetic outcome. Another critical factor we need to look at for predictable aesthetic outcome is the buccal plate thickness. We know when the buccal plate thickness is less than 0.5 millimeters, there's a huge risk of mid-facial recession, and we need to be able to compensate that with some type of graft like CTG that we talked about. But fortunately for Rob, he has about 0.94 millimeters buccal plate thickness, so we're not too concerned about the buccal collapse. So as always, the surgery is started with the atraumatic extraction of the tooth and a full curettage of the socket to get rid of any infection. And this was done in the days before I was utilizing a surgical guide. So I used this surgical stent, which is clear and helps me visualize where the final tooth position is, which helps me, in turn, position my implant, a prosthetically driven surgery. And one of my favorite implant system for immediate implant, Megagen's Blue Diamond, 3.7 by 13 was placed here. Now, according to this article and many others, when the buccal jump gap is more than 3 millimeters, there's going to be incomplete bony filling of the socket. Therefore, we limit ourselves to position the implant about 2 millimeters, which was filled with allograft as a part of dual zone grafting in order to enhance the buccal contour maintenance. And as always, as we know, Dr. Linkovich's famous zero bone loss concept, we place the implant platform 4 millimeters below in order to achieve a proper biological width. And now for anterior cases, I love immediate loading, but unfortunately in this case, we actually did not achieve a good initial stability and ISQ. Therefore, we decided on the delayed loading approach with the healing abutment in place. And everything is healed for 3 months, and you can see how beautiful the tissue has been healing. And you can see it in this view, but unfortunately the emergence profile was quite less than ideal due to the healing abutment. In order to develop the better and the best emergence profile, I like to refer to the aesthetic biological contour concept, or the EBC concept. And this concept divides the transmucosal zones, the tissues, into 3 different zones, which is aesthetic, biological, and crestal. And depending on the different zones, we need to design the abutment and the crown a little differently. From the straight crestal to concave biological and convex aesthetic, we achieve this reverse S-curve that we talked about. And so I instruct the lab to create this provisional crown with this in mind. And when we insert it, you can see how blenching of the tissue is occurring. That's telling me that the tissue is being sculpted for the better emergence profile. And in just short of 2 to 3 weeks, we can see ideal emergence profile has been reached according to the EBC concept, and we scan this emergence profile to design into our final prosthetics, which was made from final zirconia crown with a customized anodized abutment. And when we finally insert that in, you can see how beautiful everything looks, which blends and harmonizes with the rest of his dentition. And even after 1 year, everything is being well maintained. Now, we talked about the aesthetics a lot. But when we talk about it, we can say, oh, it looks good or it looks bad. But instead, why don't we use an objective scoring method for the aesthetics? Article suggests the aesthetics of anterior implant is a harmony between a pink gums and a white tooth. Therefore, we developed a pink aesthetic score and a white aesthetic score. And when we use this to grade our case, we can see how high the scores, because we were able to follow the science and the biological rules in order to achieve this predictable aesthetic outcome. And so let me ask you again, what is aesthetic anterior implant? And do you think this qualifies for it? Now, there's a famous saying, the beauty is in the eyes of the beholder. What does this mean to you, and what does this got to do with our aesthetic anterior implant? Well, in the ages of social media, we share everything, and by those things, we're influenced. And this perpetuates an unfortunate side effect where we try to standardize everything, including the beauty and the aesthetics. And it happens in dentistry because we share our cases to Instagram and Facebook, and we share the most perfect smile makeover cases with bleach white, pearly, pretty teeth. Now, don't get me wrong, this is a beautiful result. And and my last patient wanted this too. But what I'm talking about is, what I have trouble is when we, the doctors, try to force everyone into this one singular aesthetic standard. This is when I have a problem. A very interesting research that I come across with tells us that the aesthetics from the patient's perspective and professional perspective is not correlate. Due to the subjective nature of aesthetics and incompatibility of the patient's perspective with what is considered as an objectively perfect implant, an implant with the perfect pink and white aesthetic scores may in fact prove to be unsatisfactory for the patient. So despite you doing a perfect implant, your patients could still be unsatisfied. So when we do these aesthetics implant and set up these aesthetic standards, who's it really for? The word aesthetic is from a Greek term called aesthetikos, which then translates into a sense of perception. Aesthetic is never a single rule that we need to apply for. The patient's perspective of their aesthetics is a true aesthetic itself. And we need to be mindful when we are working on these aesthetic anterior cases, because that's how we truly deliver a patient-centric care. So when I start on the anterior cases, I look at it as a mission to find the beauty of the beholder. And so let's look at another case here. Carlos puts a lot of trust in me because he followed me from my previous clinic. And he finally tells me about his loose front tooth. This was diagnosed as an advanced perio and a vertical root fracture, and again, deemed hopeless. Patient was concerned about missing his front tooth and wanted the best option. Same story, right? Now, according to Instagram and Facebook, there's so many aesthetic issues here. Gingival line is not harmonious. There's a big diastema. Incisors are all malpositioned. The edge levels are all over the place. So can we still achieve a predictable aesthetic outcome despite all these aesthetic issues? Or are these really aesthetic issues? Now, other than the poor hygiene and all that, when I asked and pointed these aesthetic issues to the patient and asked, hey, Carlos, are these important for your smile? Patient said no. A single question can really communicate what is aesthetic between you and your patients. Communication is at the heart of patient care. Without proper communication of aesthetics, despite our perfectly placed implant with perfect pink and white aesthetic score, your patients could be unsatisfied. And so based on his aesthetics, we designed the case. And this is where digital dentistry really shines, helping us to visualize the future. And as per patient's request, we just duplicate the patient's tooth. And due to the asymmetrical spacing, we have to utilize the surgical guide. Otherwise, a malpositioning of the implant could occur. And with 0.89 millimeters of buccal plate thickness and a thick gingival biotype, I'm not too concerned about the buccal collapse. So again, we start with the surgery, remove the tooth atraumatically and correct the socket. And a surgical guide with Artugate kit was utilized to prepare the osteotomy and place the implant. And this time, 4.1 by 13 megagens blue diamond was placed. And now it doesn't really matter if the prosthetic is atypical. We still need to follow the biological rules. Therefore, we place the implant 4 millimeters deep, buccal jump gap less than 3, and a dual zone grafting. And this time, the initial stability was good, so we performed the immediate provisionalization, where we make it out of the printed temp shell, picked up intraorally, and this still needs to follow the EBC concept for proper biological, proper emergence profile. And this is what patient goes home with. And 2 weeks later, everything heals up, and it's beautiful. But the patient comes in and complains to me. And I was truly shocked because I couldn't understand. Everything looked right to me. But the problem was, it was a miscommunication. Patient wanted a diastema on the mesial and on the distal. I don't understand why, but that's what patient wanted. So we decided to correct for these issues with the secondary provisional, which was made by the lab now. And I talked with my lab guys to make this provisional using exocad and photos. And also, once I insert it in, my patient comes back for 5 times. 5 straight times in order to correct for little edges here, little rounded corners here, and more spaces here, until we finally find the beauty of the beholder. And so we use digital intraoral scanner to duplicate the final emergence profile and the crown shape. And when we make the final prosthetic with zirconia crown and custom anodized abutment again. And here is what it looks like after it's inserted. This final result may not be your typical Instagrammable case because it scores very low on our objective scoring board. But the patient is happy because this is his perception. And who are we to deny of his happiness? So when we have these both cases side by side, what do you think is more aesthetic? I've done many anterior implant cases, but I've done them all with the same mission, a mission to find the beauty of the beholder. And that beholder is always our patients. We talk about anterior implant cases because we all want predictable aesthetic outcome. Predictability comes from the science and adherence to the biological rules, whereas the aesthetic comes from our communication with the patient, and digital dentistry helps a lot in this situation. We need to give individualized attention to our patients to achieve the most patient-centric and a predictable aesthetic outcome, because we're here to serve our patients, and so I dare say my ultimate mission of dentistry is to serve our patients to the fullest. And so, we're in France, so as the French would have said, sois belle à ta façon. I wish you be beautiful in your own ways, and I encourage you to find the unique beauty in your own patients as well. Thank you for listening to my presentation.